Good afternoon. And today we have an honor to interview somebody who I've been following for years, my favorite speaker, Dr. Jamison Spencer.
That's very
Good
kind of you.
afternoon, doctor.
Good afternoon.
And I'm going to, first of all, thank you to our audience. If you have sleeping problems, or if you sleep next to the snoring partner, please click the like and share button. Or if you're a medical professional who, just like us, are very passionate about problem with sleep and breathing in the same time, please use my channel as a networking ground. This way you can meet like-minded people, and together we can find all missing puzzle of that tricky disorder called sleep apnea, which can represent in so many different shapes. And today we're gonna use that topic and talk about sleep apnea as well as application to temporomandibular joint. A lot of people have both of it, and they know or they don't know it's related. So we're gonna talk about that. And let me introduce you, Dr. Spencer. First of all, Dr. Spencer is a founder of Spencer Study Club, and you can see the beautiful poster behind him. And it's a very respected institution, and a lot of my friends are part of, and I've been on a lot of events of Spencer Study Club. And that study club actually shined the light on temporomandibular joint disorders, sleep apnea, and a very controversial topic of applying that toward practical everyday practice. We're talking about medical insurance or not, some financial situation with that. And Dr. Spencer, he's a past president of American Academy of Craniofacial Pain and a diplomat of American Board of Craniofacial Pain. And he lectured in multiple very respected institutions and all over the world. And he's such a great speaker. And he also has a wonderful family. And I met his whole family. And they actually on the board of helping him to run this organization of Spencer Study Club. And my first question to you, I want to mention that what I really admire about you as a lecturer, you have a lot of deep anatomical knowledge. And I'm a very foundational person. I finished 2 medical schools. I really like how we start from the bottom and build it up. So my first question to you, as a founder of Study Club for temporomandibular joint disorder and sleep apnea, could you please explain temporomandibular joint disorder from anatomical perspective and how they relate to sleep apnea patients who grind and experience pain in the jaw joint?
Sure, and thanks for having me. I like to say, Maria, that I'm not smart enough to understand like neurochemistry and things like that. So anatomy, I can get my brain around. The nice thing about anatomy too, it's been a pretty much dead science for a few hundred years now. So you don't have to keep up on the literature of like some new muscle they found or whatnot. But the complexity of the stomatognathic system, this using of our jaw and the muscles of mastication and the jaw joints. The jaw joints are so complicated, and it's a rather amazing system. The fact that you and I can speak the way we are and things like that and not bite our tongue and whatnot is quite amazing. So actually the answer to your question though on the anatomy always comes down to diagnosis. What is the person's problem? So there's a big difference between someone with a clicking jaw versus a locking jaw, versus somebody who is having bruxism possibly due to their sleep apnea, which maybe we'll talk more about in a minute, or someone who is grinding or clenching their teeth due to emotional stress. So we are always in our field, we're trying to get down to the etiology, but that anatomy does come in. And one of the things I really look at is overuse of the anatomy. Someone who rarely spends any time with their teeth together, only when they swallow and chew, what I call 1% occlusion.
I love that concept. I really want to shine the light on that.
Yeah, so 1% occlusion is one of the things I really talk about a lot. People who are spending 15 minutes or less a day with their teeth together, they'll almost never have problems. And as dentists, we see this all the time, that we see people with what we call poor occlusions. Their teeth don't fit together right or things like that. And they're fine. They're eating what they want. They don't have pain or dysfunction. They don't have headaches. And then sometimes we see people with really beautiful occlusions. They've had orthodontics, let's say, everything's coming together well, and they're in tremendous pain. So it's not always the what you have, it's sometimes what you do with what you have. So the anatomy is important, but it's also what you're doing with the anatomy. And one last comment on anatomy that I'm really excited about is in our study club is really the leaders in this field, but we are introducing regenerative medicine techniques to TMJ problems, specifically intra-articular in the joint problems. And we're seeing reversal of arthritic changes uh, from using PRF and PRP, just amazing stuff that really is changing the world of how we treat these problems versus how we were just doing it 3 years ago. Really exciting stuff.
No, that's great. And I want to mention, we recently published the interview with Dr. Gellerman, and I want you to comment on that as well. She's using CAT scan. She was one of the first people in the country who got CAT scan in 2006, I want to say,
Yeah.
or maybe before, but really for a very long time. And she does. She sent it to radiologists to have a full report. And she noticed, she commented on that, she suddenly sees so many degenerative joint disease.
Yeah.
And my own personal experience, what you do, yes, you mentioned about diagnosis, but a lot of people come and, people looking for unicorn, and sometimes that unicorn would be oral surgeon who does the TMJ surgery. I would like your opinion of somebody who treats temporomandibular joint disorder for the whole career. What's your relationship with the surgical approach towards joint?
Yeah, so I love oral surgeons. Maria, that in our profession, the oral surgeons are they're just so smart. They're really the top of our field, and because of that, in my experience, I only know a couple oral surgeons in the entire world who advocate open joint surgery. So the vast majority of surgeons, a quick story on that. So we took over practice in Salt Lake City. The previous doctor, there was a TMD only practice. Now we do TMD and sleep. But the previous doctor was sending a lot of people for arthrocentesis and other type of surgeries. And the surgeon that this previous doctor worked with is a great guy. And we started doing things a little bit different. We rarely refer people for surgery. I've unfortunately had a few people have negative experiences with open joint surgery, and that hurts me as a practitioner. I don't ever want to make people worse, and the surgeons didn't want to make them worse either, but just the outcome, unfortunately, that was the case. So we're very conservative on our treatment. And we have a procedure that we do to help get someone's disc back into place, and just involves an injection, a gentle manipulation, using a splint immediately after. We talked to this oral surgeon about this procedure. He brought his wife in for us to do that procedure on his wife. And after that, I just talked to him the other day. In the last 2 years now, he's gone from doing joint procedures probably weekly to almost never. As a matter of fact, he even said in his practice now, if you called up and said, hey, yeah, I've been referred to you for a possible surgical procedure, he'll say, well, no, you need to see Dr. Mangelson, my partner in my Salt Lake practice, prior to us even talking about surgery. So and now with our regenerative techniques, I really think, Maria, that the era of open joint surgery is coming to a close.
I really love it.
And I think that'll be really good for patients. We're seeing tremendous results with regenerative techniques almost every time. It's not 100%, but it's almost every time.
That's we talk on that. Surgery or referral to surgery, it's a marriage to oral surgeon.
Yeah.
Because it's just gonna go over and over and over and over. And as a high level professionals, we don't want our patients to go through things multiple times. It doesn't put a good taste in my mouth.
Of course.
Specifically. Now I want to go back about, I want to point out to our audience. So instead of surgery, Dr. Spencer advocate regenerative joint technique with some plasma injections, and Spencer Study Club offering that educations to the member. And I think it's a really progressive step and I want to learn it myself. So that's a lot of hope in that for TMJ, people who suffer from temporomandibular joint disorder. And as a I want to mention that whenever I have a conversation with the medical doctors and I talk to them about oral appliance therapy, maybe that can help their patients who not so, excited about CPAP therapy. They always said, what about temporomandibular joint pain? They all so scared about the bite. The survival of the patient is a different story, but what's going to happen with the bite? So as somebody who does it every day, yes, it's true. But a lot of sleep apnea patients suffer from temporomandibular joint pain,
Right.
or a lot of temporomandibular joint patients who suffer from temporomandibular joint pain might have that discovery. So, what are some effective strategy you manage temporomandibular joint pain in those patients, considering complexity of that condition?
Yeah. So you mentioned, Maria, a few minutes ago about cone beam CT and how that kind of changed our paradigm, and that was my way. That was my case too. I came straight into from dental school into a TMD only practice, and after a few years, we started treating sleep apnea because we were using these oral appliances both in TMD and in sleep apnea. But I treated those people as separate kinds of people. Like there was sleep apnea patients, there was TMJ patients. They had nothing to do with each other until I got the cone beam CT. That's really what opened my eyes that, hey, a lot of these people presenting with TMJ problems may actually have sleep apnea, because I would see a small airway. I would see these other things. We'd start asking questions about snoring and bed partner report and all that stuff. And now, fast forward, roughly 60 to maybe even 80% of our patients who present with a chief complaint of a TMJ disorder, we screen them and they very likely have sleep apnea. We refer them to our medical colleagues. They get sleep studies. They almost always have sleep apnea. And then the really exciting thing is, as their sleep apnea is treated, be that with CPAP or oral appliance therapy, a majority, if not all, of their TMJ problem will resolve. Now, the concern that our physician colleagues have on creating a TMJ problem comes from this notion that we're going to bring the jaw forward and that's going to somehow hurt the jaw joint. Back to our anatomy lesson, that's if you protrude your jaw right now and hold it there, if the watchers do that and just hold their jaw forward, it's going to take about 15 seconds before they're like, oh, that kind of hurts. But the thing is, with oral appliance therapy, that's not what we're doing. The person brings their jaw forward and then the appliance holds it forward. They're completely relaxed. So it's not increasing muscle tension. It's not doing anything anatomically negative to the jaw joint. As a matter of fact, it's bringing the jaw joint into a potentially better position to take pressure off the jaw joint. We did a quick study at when I was out in North Carolina. I did a quick study at UNC where we took 10 people with known sleep apnea and personal complaint of TMJ problems. We fit them with oral appliances, tracked them with home sleep testing to see that their sleep apnea was getting better, and tracked their TMJ disorder self-report during that time too. Every one of those 10 patients, as their sleep apnea got better, their TMJ pain got better. Okay. And that's what I see in my practice all the time. The one mistake that a lot of us dentists make, and it's a non-intuitive thing, but sometimes we start people with oral appliances. Here's a quick quote from a friend of mine, Lieutenant Colonel Philip Neal, who you've probably heard him speak before, Maria. He said, with CPAP, we start with efficacy and we chase compliance. With oral appliance therapy, we start with compliance and chase efficacy. Said a different way, CPAP always works. We just need the person to use it. With oral appliances, patients almost always wear them. We just don't know if they work. So one of the problems with an oral appliance is we start off in a position that's a bit of a guess. And then sometimes the patient gets better. You know this, Maria. A ton of our patients, like literally first night, they're like, oh my gosh, I'm doing amazing. My wife says my snoring's gone, awesome. But not everybody does that. And sometimes we'll have a patient that says, oh, I'm having jaw pain. And the average dentist will say, oh, Okay, back it up. You're too far forward. That'll be the intuitive jump, is we've protruded you too fast. And I think that's usually wrong. All we have to do is ask, well, how's your snoring? Oh man, I'm still snoring like crazy. How are you sleeping? I don't feel I'm well rested at all. Okay, let's take you farther forward. Okay, with CPAP, they, especially in the olden days when they used to titrate it live in the sleep lab, they knew where to set the pressure. Now with auto set CPAP machines, the machine knows where to set the pressure. With oral appliances, it's up to us dentists to communicate with the patient, figure out where that jaw needs to be. But I can promise the listeners here that if they ask those questions and the patient's like, I'm still snoring and I'm not feeling well rested, they should probably take that jaw farther forward.
No, thank you. That's such a great answer and cover several areas. I would like to ask you about sleep tracking.
Sure.
A lot of that's such a common question. From your experience, what wearable device you recommend for patients to wear to track their sleep? We're kind of moving to the future.
So the very best wearable sleep tracker is the one the patient will use. That's the best one. So I have a Garmin watch. Now, this is as big as it gets. Okay.
And do you sleep in it?
I do. And I didn't for a long time. And then I'm like, boy, that's going to be so clunky to sleep with this thing on. And now I'm totally used to it. But there's the Aura Ring. There's the Whoop band, which I'm really excited about because the Whoop band can go on your ankle. It can go in all sorts of different spots on your body where no one would even see it, which is pretty cool. And all of these, the Apple Watch, the newest Apple Watch is fantastic. All of these are using similar technology, and they're able to track heart rate variability, which is really important, pulse oximetry, and from that data, also actigraphy, so movement. And from that data, they're able to give you pretty good data on sleep staging, obviously your oxygen levels, things like that. So I love the idea. I'm almost addicted to mine now. One of the first things I do every morning is my watch. When I wake up, it says, hey, do you want to kind of end your night report right now? I check my phone. I look at, I'm an athlete too. So I ride bikes. I run, I ski in the winter, I do all this stuff. And I'm looking at, well, what's my recovery level? What's my training level? So I really do think, Maria, that these are super great. Also, a caution. If I was in treatment for oral appliance therapy and one night my sleep wasn't that good, I wouldn't call up my dentist and be like, hey, I think my appliance has a problem. I would look first to, well, did I eat late last night? How was my sleep the night before? Did I run extra far? Did I do a 10 miler that day? I would look at this other stuff. And that's the key for our patients, I think. Because you and I, we treat people with an oral appliance, and that's part of the equation. Our physician colleagues give people CPAP. There's 1,000 other things that can make people tired other than an airway issue.
Of course.
The sleep trackers help us as physicians, as dentists, as physicians, help our patients better.
I personally think that sleep tracker increase the compliance because it's become interactive thing. My goal, one of the goal of my channel, to make the therapy I offer cool, exciting, and that's the one. And my last question to you, very controversial question, I also get a lot from medical doctors dealing with medical insurance for sleep apnea, and that can be challenges. What strategy do you suggest? A lot of my friends, they say, oh no, I'm only fee for service. I do feel for my patients. I learned for many years how to deal with the medical insurance. I have a whole department. So tell me your strategy about medical insurance and what you advise to members of your study club.
Yeah. So, and you just hit the nail on the head, Maria. You said, I feel for my patients. And that's the only reason, in my opinion, to work with medical insurance.
True.
And I think all of our medical colleagues would agree too. They're a little different. Medical doctors, it's bizarre when they aren't working with insurance. For dentists, it's fairly normal for dentists not to work with insurance. But the reason for us to work with insurance is we will inevitably help more people because it will make treatment more affordable. Having said that, your average dentist who's going to try to help people with sleep apnea, with snoring in their practice, they're not like you and I, where they're going to focus all of their efforts on this. They're doing all sorts of different things in dentistry, and for them, I would say, hey, it's very complicated. Like you said, I have a whole department. Yeah, me too. I have like 5 people. That's all they do all day, and they're on hold all day long. And I've seen this as the number one reason dentists give up
Of
on
course.
helping people with sleep apnea is insurance. And that's sad. Okay. What I think they should do is tell the patient, hey, I can help you. Here's my fee. Here's a reasonable fee. But if insurance coverage is the most important thing to you, I'm going to send you to my friend Maria. I'm going to send you to my friend Jameson. They're in network. Now, a dentist may hear that and go, well, that's rather self serving. No, it's not, because you'll have a lot of patients. You'll be surprised by this. Most patients will stay with you because they trust you. They know you. They don't want to drive across the bridge to Maria. They want to go where they know somebody, or they've got a $5,000 deductible. They're going to pay out of pocket anyway. So my main advice for dentists getting started in the field, just be fee for service, keep it simple, help people as much as you can. If insurance is the most important thing, there's probably a Jameson Spencer, there's probably a Maria near you. Work with them, they'll be pleased.
Thank you very much. We really appreciate having you.